What's up, everyone? My name is Drin, and this is Drin the Moment. Today, we're going to be talking about things I wish I knew before I became a psych nurse. If you're not one to watch a whole video and you just want to know the things, there's top 5, I guess the ones that I came up with for right now. They are Diagnoses, Collaborate, Fill Your Cup, Staffing, and Stigma. All right, let's get to it. The first one is Diagnoses. Knowing which diagnoses you like taking care of versus the one that you struggle with. I almost didn't want to include this on the list, let alone start with this, because I truly believe it takes time and experience, but it's worthwhile thinking about the diagnoses. A shift taking care of an acutely manic bipolar patient is going to be vastly different than taking care of someone that is withdrawn, isolative, depressed, and anxious. I personally love and feel like it's nursing strength of mine taking care of patients with anxiety and depression. I don't necessarily enjoy and find difficulty in taking care of an acute manic bipolar patient. The hyperverbal, tangential, racing thoughts, no sleep, no insight type of manic. If you're a new graduate nurse, which I'm assuming many of the people that click on this video will be, I suggest trying to get a feel or imagining the type of patient population that you would like to work with in the psych world. Number 2 is collaboration. Knowing the other members on your treatment team will make your shift smooth as butter. In my first year as a psych nurse, I would follow orders to a T, not ask questions, and most concerningly, not take patients' experience into account. For example, one of the main nursing tasks that need to be completed daily is a med pass. As a new grad, I was focused on making sure that I pass the medication on time and don't make any medication errors. What this meant is that I would do everything in my power to make sure that a patient took a medication, whether they knew about it or not. I say whether they knew about it or not because there have been many times in my new grad year where I didn't take into consideration everything that goes into medication management. If there was an order and it was on my MAR, it was my job to administer it. However, it is also our job to advocate. I recently had a 19-year-old patient, A&O times 4, in well decision-making capacity. Their inpatient psychiatrist met with them for about 15 minutes before suggesting lithium as a new medication. This patient had already voiced not wanting to try medication as their first-line intervention while inpatient. The psychiatrist had not relayed to me that they had the conversation with this patient, and the only information I had was that new lithium order. So I pulled the medication out of the med cabinet and made my way to the patient's room. New grad me would have said, "The psychiatrist ordered new medication for you. I'm here to give it to you now." To which they would refuse, and I would go, "You need to take it. The doctor ordered it." It's kind of cringe for me to think that I used to work that way. On the flip side, with collaboration in mind, I actually said, "It looks like the doctor ordered new medication for you. Did they talk to you about it?" After hearing their answer, I provided space for them to express their feelings about starting a new medication and beginning medication education should they welcome it. This is just an example of working with a patient-doctor dynamic. There are numerous other members of the treatment team that you need to consider. The goal is to think about the whole experience for the patient. The importance of your nursing task may not be all that important in the grand scheme of the patient's admission. Number 3 on this list is staffing and floating. You're gonna want to know the grid and the nurse-to-patient ratio of your unit. You'll be surprised to know that knowing the grid of your unit can really make or break your time as a nurse. The grid is what tells staffing how many nurses your unit needs or doesn't need based on the number of patients currently admitted to your unit. Some grids consider patient acuity and some don't. This is what you'll want to find out at your job interview. When I worked in California, it was 1-to-5 ratio and no more than that. I currently work in Illinois and it's 1-to-5-to-7 patients. 5-to-7 is doable, but when we get into the higher numbers, my patient care for the individual patient definitely decreases and my mental capacity is definitely worn down. The second part of this is floating. Floating means to float to a different unit that is not yours. There's pros and cons of floating. A pro being if you're worn down by your patient population, you get to experience something new by going to a different unit and having a different patient population. The first psych unit I worked on was a freestanding psych hospital with 7 different units. So I had 6 other units that I could float to. Currently, I work at a hospital with only 1 psych unit, so I don't float anywhere. It's great for me because I actually hate floating. The usual flow and routine of my day is thrown off, and I'm not working with my usual coworkers, which isn't all that fun for me. Number 4 is fill your cup. I'm sure there's a saying out there that goes something like, "You can't pour from an empty cup." The difficult part of psychiatric mental health nursing is the toll that it could take on your own mental health. It takes patience, resilience, understanding, and empathy to be an effective psych nurse. To maintain optimal levels of these characteristics, it will be very beneficial to assess your own views on mental health, specifically your own mental health. A couple questions that you can consider are, What are your own strengths and weaknesses? Do you know your own warning signs? What coping skills do you utilize? Do you have a self-care practice? Answering these questions can help ensure that you'll have enough energy to tackle what it takes to be a psych nurse. Finally, number 5 on the list is stigma. I'm not sure if this is something that I wish I knew before I became a psych nurse, more so as something I knew and expected coming and how to handle it. It's unfortunate that mental health stigma exists. It's increasingly unfortunate that it still exists in the nursing world. When I picked psych as my specialty, I got a lot of pushback from family, friends, professors, saying that I need to go to med-surg, I need to practice my medical skills, because if I do psych first, I'm going to lose them. So I want to get this very clear. Being a psych nurse does not mean you are not a real nurse. You don't have to be popping in IVs and dressing wounds to be a real nurse. I'm saying this because even though I logically knew it, I truly didn't believe it. In my first years as a new grad and as a psych nurse, I've definitely had my handful of self-doubt thoughts. I thought to myself, what if I do lose those skills? Do those skills matter if my current trajectory is to be a psych NP? These thoughts of self-doubt became so great that I gave in, so much so that in my 3rd and 4th year of nursing, I explored med-surg and ICU just so I could prove myself. And although I enjoyed enhancing my time management skills in med-surg and gaining critical care experience in ICU, I was left with a simple fact that psych nursing is the specialty for me. If you intuitively feel like psych mental health is your calling, don't let the stigma that currently exists force you to do otherwise. This is not an exhaustive list. If there are any questions of expectations that you might be thinking for your first job as a psych nurse, leave it in the comment section below and I'll try to answer them. Thank you for watching this video. Until next time.